Good afternoon, everybody. For those who I've not met before, my name is Ian Sheldrake, and I'm a principal at the NAOS Group. It gives me great pleasure to introduce the fourth in the series of webinars with Dr. Norman Swan on the long-term implications of the COVID pandemic. These webinars have been organised by the WA Primary Health Alliance, are sponsored by the NAOS Group, and are raising money for a great cause in Youth Focus. I'd like to acknowledge that Norman and our guest experts today have donated their time to participate in this webinar. So on behalf of the WA Primary Health Alliance and Youth Focus, I'd like to thank you all for your generosity. I'd also like to acknowledge that we have people dialing into this webinar from across the country. So with that in mind, I'd like to acknowledge traditional owners of the lands from all of this great nation and pay respects to elders past, present and emerging. The format for today is going to be a facilitated discussion, facilitated by Norman Swan. We'd like to invite you to ask questions throughout. At the bottom, you should see a Q&A button. Please do click on that and ask questions at any point. Norman will be monitoring them and answering them at appropriate points in time. So with that in mind, I'd like to hand over to Norman, who'll introduce today's topic and today's guests. Thank you.
Thank you very much, Ian, and welcome everybody to this webinar. One of the common topic points when you're talking about COVID-19, we've already covered long COVID in terms of the physical effects, but the impact of lockdown, the impact of an economic downturn, the economic impact of more people being unemployed and delays in economic recovery, the psychological impact of schools being shut, homeschooling, but also universities and opportunities for advanced education. All those things have an impact, and many more. Just being stuck in one small place with your partner, stretching relationships. All those things have an impact on mental health. And the question is, how will it last? What sort of effects will there be? Have we learned any lessons? Are we tooled up to deal with these mental health problems moving forward? Because as we've flattened one curve very successfully, probably as successfully as any other country in the world, if not more so, are we now seeing another epidemic curve emerging, which is an epidemic curve of mental health issues and possibly suicidality? And what can we do about it? The audience today is largely focused on the primary health sector through PHNs, general practice and elsewhere, multidisciplinary sense and government. And I encourage you to ask questions, make a comment. I'm just opening up the Q&A box as I speak. As we go along, don't wait. Just whenever something occurs to you, just stick it in that box so I can bring it into the conversation in real time. I may or may not leave time for questions at the end, because often what I find is that your questions add flavor and depth to the discussion we're already having. Our three guests today, our panelists, are Joanne Atkinson, Associate Professor Joanne Atkinson, who's at the Brain and Mind Centre at the University of Sydney. She's head of systems modelling there. Joanne's group and Joanne's expertise is almost unique internationally in terms of modelling in the social sector, modelling in mental health, looking forward and bringing together complex systems, complex data from wide sources to make accurate, not accurate, but modelling doesn't give you accurate predictions, but tells you the way things will go when you adjust the variables. And if you don't adjust the variables, what might happen, with some surprising findings, which you'll discover in a moment, where things that you think might have helped don't necessarily help. They could well make it worse. Our other guest is Dr. Caroline Johnson. Caroline's a general practitioner in Surrey Hills in Melbourne. She is an educator in general practice, involved in the postgraduate training of GPs in mental health, and has completed a PhD related to how people experience depression. Tim Marnie is a principal at NAOS Group, and like many of the consultants at NAOS Group, he's actually done other stuff and significant stuff. In Tim's case, he was the West Australian Under Treasurer for many years. He, financial reform in the sector. He was WA's Mental Health Commissioner for 5 years. And in fact, the Mental Health Commission in Western Australia, Tim will correct me if I'm wrong, but it's actually, I think, the only mental health commission in Australia which actually has a budget and directly involved in running services, rather than just having a dotted line and an advisory or keeping the bachelor's honest role. It's actually a direct service role, and has also been an advisor to the Productivity Commission inquiry into mental health. So we've got a great panel for you, lots of opportunity for discussion and engagement. Joe, just give us a flavor of how you model in mental health. What do you bring together to be able to make what kind of predictions for whom? I think your mute's on.
Sorry, you can hear me now?
We can, and
Great.
Much better for it.
Hello. So what we do in systems modelling is bring together best available evidence, and in mental health we've got decades of evidence and data to draw on, with expert knowledge and importantly the voices of the diverse perspectives of people with lived experience. We bring all the best information together to develop a systems model, and we're considering the interrelationships between things like unemployment, domestic violence, substance abuse, homelessness, early life experiences, and how these interact to increase or decrease levels of psychological distress, and also how people with levels of different levels of psychological distress interact with the mental health system. And so we're capturing all the interrelationships and dynamics of all of that, and looking at what impact that might have on changes of levels of psychological distress, on ED presentations, on wait lists for primary care services and specialist mental health services, and on self-harm hospitalizations and suicide deaths.
How good is that data? I mean, we often hear in mental health the data's crap. We don't know what's going on. We can't make predictions. How would you know? And then the accuracy of the interrelationships and the causal, because you really got to be able to say there's a causal interaction here.
So traditional traditional kind of analyses look at the relationship between a risk factor and the outcome of interest, but and they're really just looking at associations. But what systems modelling does is represent a causal hypothesis of how all these risk factors interrelate to produce these mental health outcomes. And because it's a hypothesis of how the system works, we have to test it. We have to see if it can reproduce historic data. And so we test the model to see if it can reproduce those levels of psychological distress and self-harm hospitalizations, ED presentations and suicide deaths over the last 10 years. And when it can reproduce what we've seen historically, we can have some confidence in the forecast moving forward.
So give us a sense of some of the work that you've done. I know you've done work on the north coast of New South Wales. You've also done work in Western New South Wales, and you've come up with some counterintuitive findings.
Yes, so what we've kind of modelled systems at a national, state and regional level. And our modelling really kind of tells us that we need a kind of coherent response across health, education and economic sectors to tackle this mental health problem. So things like extending employment programs such as JobKeeper was the single most effective intervention in preventing suicides over the next 5 years. We also need investments in education programs and, of course, increased investment in growing. Oh, sorry.
Well, before you get there, I mean, I think there's a step before that to understand. I just want, before we get to COVID in particular, I just wanted to illustrate how when you plug in certain things, particularly the Western New South Wales example, which I was always struck by, which is when you do something you think makes sense, it could make things worse. It's just that cautionary note before we then get into COVID.
Right. I'm with you. So yes, when we went to, we modelled the system in Western New South Wales. We have good evidence that GP training improves referrals to specialist mental health services and can have good effects. We've also had there's also evidence to suggest that mental health education to reduce stigma and increase treatment seeking has good impacts. The problem was that when we introduced these interventions in the Western New South Wales systems, what they did was their job.
This is in the model.
In the model, sorry, yes, in the systems model for Western New South Wales. When we introduced them into that system, it actually increased the forecast for suicide. And so we thought, oh, there must be something wrong with the model. And so we went back and had a detailed check. But what we found was happening is because the service system is constrained and was already at maximum capacity, driving more people into an already stretched system increases wait times, increases disengagement with services because people have to wait too long. It increases ED presentations and increases suicide because people don't feel that the service system can help them. So it introducing even evidence-based interventions into complex systems can have unexpected impacts.
So the answer there was presumably that you go downstream to fix up the services before you teach people about mental health.
Yeah, so it's the timing of, so we need to increase service capacity first. So we ran those scenarios where we increase service capacity first ahead of driving more people, ahead of doing the GP training and community awareness to drive more people into care.
So let's now move to COVID-19. It's taking a little while for us to clear our throat, but I think it's important for people to get the basis, and not everybody watching is familiar with the modeling in this area. They are, although with the biology of the COVID pandemic. So how have you modeled mental health moving forward in COVID-19, and what have you found just in terms of the patterns before we get to the solutions?
So what we've seen, and it's a little bit kind of difficult just to talk about and not show, but I can certainly provide all the links to our reports that have some good visuals in there to show the audience at another time. But what we're seeing is this kind of what we're anticipating, what the model is projecting is an increase in those adverse mental health outcomes over the next 5 years as a result of the social and economic impacts of COVID-19. And that is the decrease in social connectedness, as well as the effects of the recession and unemployment.
And in terms of plugging in solutions, which is what you were getting to a moment ago, but I want to bring you back to that.
So we modelled a range of strategies that government were thinking about at the time, and we started this work in April, May. So we put in JobKeeper, which was broadly employment programs, and we modelled it for 1 year, 2 years, 3 years, and 5 years, and we found that it alone was the most effective intervention out of all of the ones that we modelled, and that keeping it in place for 2 years was the ideal period of time. Removing it after 1 year, removing it too early, just kind of creates a kind of kickback in the model. We also found that we needed the modelling really helps. You can turn on and off the different interventions individually and see what happens, but the advantage of this sort of modelling is to look at what works best in combination, what combination of interventions work best together. And the combination was the extending JobKeeper until May 2022, investing in education programs, and the way we modelled that was financial support to students who've become unemployed to enable them to keep studying, as well as increasing the enrolment rate of young people in post-secondary study by about 20%, which in itself is quite ambitious. Also, post-suicide attempt assertive aftercare to help those that are at greatest risk of reattempt. We need to significantly increase investment to grow mental health service capacity in the order of 8 to 10% per year, which is substantial. But importantly, it's not just an increase in service capacity, but we need to better coordinate care across teams of service providers, potentially enabled through technology.
So it's 6 months or so since you've done the original work. The lockdown lifted in May, hasn't had to be reimposed anywhere but in Victoria, for a couple of days in South Australia. And say Queensland is saying, oh, well, they're not seeing increased presentations yet, and other things saying, so the modelling was rubbish. What's your response to that?
There's usually a delay, and some of the things that government have been doing obviously have been working. So JobKeeper is still in place currently. There've been some other financial supports to support people and reduce financial stress. There's usually a delay, but what we haven't yet seen the uptick in suicide deaths, but we're not suggesting that won't happen. We hope it won't. But what we are seeing are the early precursors to that. We're seeing increase in presentations. We're seeing huge increases to calls to helplines, and we're seeing increased self-harm hospitalizations. We kind of trying to keep the pressure on in terms of the things that are needed to keep the pressure on and make sure that we don't end up seeing this suicide curve.
And if you're running a PHN or a large general practice, what are the implications of this for you?
Well, the national modelling hides, the huge variation you see across PHN. So we are a strong believer in making sure that these models are actually parameterized and used at a regional level, so that includes all the regional parameters and issues and barriers that are unique to particular regions. So it's also important to see this modelling as, not something that we use as a once-off to help, deal with the challenge of COVID mental health issues, but we embed it in an ongoing monitoring and evaluation cycle. So as new data comes in, we can improve the model over time. We don't suspect for 1 second that we would get a perfect model the first time we build it, but as new data comes in and we can refine the model and strengthen the model over time, it becomes a really valuable long-term decision support asset. And so we're investing in that approach.
So Marnie, this modelling is pretty unique internationally. What do you think about it, and does it chime with you in terms of mental health service planning?
Yes, thank you. And thanks, Joanne. That was a really good summary of some of the work that you've been doing. The modelling is incredibly important. And I think in Australia, we probably do it as well as anywhere.
Yeah, but government's not listening. I mean, Hunt has deliberately not used this model. He says he is, but he's not.
Yeah, it varies by jurisdiction. So, for example, in WA, I used the National Mental Health Service Planning Framework and modelled the demand, which also then matched against a woefully inadequate supply. Yet the government allowed me to publish that and be very public about the lack of particularly earlier intervention, community, psychosocial supports and services. And I think our system is so heavily skewed towards acute events that the acute end can never cope with the flood of demand that comes to it by virtue of an insufficient supply of earlier intervention services and supports. So the modelling shows that very clearly and very starkly. I think you're right to say that decision makers haven't necessarily responded fully to that yet.
So what, if you look at the lessons we have or have not learned from COVID, what if Joe's modelling is right, then if they drop the ball on some of these interventions that are going on now, so what we're seeing now is some of the benefits of if prevention works, nothing happens. So you can blame the modelers, or you can say, well, thank you very much for being doing the right thing. But if they stop doing the right thing, you'll see a surge coming back. What's your view of what we're going to see post-COVID in mental health? What we need to learn?
Well, I'm actually trained as an econometrician, so Joanne's modelling fascinates me, but I think it's as good as it can be. But what we've seen is an unprecedented and prolonged event of massive economic, social and health impact. That to me says we've got a structural break in how those relationships all work. And in fact, what we're going to see is probably underestimated by the modelling by virtue of that structural break in the data.
So can I just ask you what you mean by a structural break?
So we haven't had changes in some of the key parameters of this magnitude ever before that we've measured. So for example, the impact on small business, single owner operators, that real sort of engine room of the economy and the big employers across the country have been so incredibly impacted that previous data series don't give us insight into the consequence of that. So I think what we're going to see is quite different to even what the modelling says. And we won't see it until, middle of next year, second half of next year, as the lagged effect of prolonged situational distress for people starts to really take its toll.
So what you're talking about there is just this massive disruption, which is a game changer, and we're not quite sure what the game is unless you use modelling.
Absolutely, yeah. And the benefit of modelling is you can run those scenarios. You can understand what impacts different interventions have at what time and to what extent, which is exactly what Joanne summarised in terms of JobKeeper.
And how well, let's now look at just moving forward. I mean, if you look at, so at one spectrum, you've got suicidality, attempts, self-harm attempts. At another end, whether it's continuous or not, it's a very complex situation. You've got distress, and I'll come to Caroline in a moment about distress. Just tell me how you think that pathway works in a disrupted environment such as this.
Actually, can I start by just acknowledging all those affected by mental health issues and suicidality as well? The pattern is very different, and I think suicidality and situational emotional distress are going to be far greater in prevalence as a result of COVID-19 than was previously the case. And that'll manifest in a number of different ways and ways that we can't quite anticipate yet. So for example, in WA, during COVID, for some reason, whether it was COVID related or it's just a coincidence, the number of child and adolescents in hospital receiving treatment for eating disorders has quadrupled. Now that, at face value, yes, at face value, that doesn't really make sense, but reality is it's happened. Is it related or is it a coincidence? We don't know these things yet.
And just in terms of, you're sitting in a state which has had no community spread for a long time, effectively no virus in the community apart from maybe the odd ship arriving in Fremantle or Port Hedland. So what you're suggesting here is that distress occurs even in a state which got over COVID, as quickly as any other, you in Queensland particularly.
Yeah. I think, although there's not been community transmission, the anxiety with respect to COVID and certainly sitting inside a bubble and watching what's happening in Victoria and New South Wales means the distress for people can continue, even though, we've been an island within an island.
So let me ask you the same question I asked Joe a moment ago, which is that you're watching this and you're running a primary health network, or you're running a government service, or you're running a large general practice network or something like that. What does this mean for you? apart from patient load, but what can you do to actually put your shoulder to the wheel here?
I think the issue is not to wait for a mental illness to be diagnosable. I think situational distress is the front end of the curve in this space, and understanding a patient's circumstance and what's happening to them in terms of their relationships, finances, employment, and so on, is pretty critical as really the social determinants of mental health and well-being. So I think if I was a GP in a clinic, I'd be asking questions that I probably hadn't asked before about people's current situational circumstance.
You want to know about their lives a bit more.
Yeah.
So Caroline, I mean, what we're talking about here is something that you might just be seeing the beginnings of, but the truck is only going to hit you next June or July if the modelling is right, not now. You might see some hints of it. Do you think general practice is ready for it? And what are you seeing in Victoria where you've been doing it toughest of all?
Well, I certainly think it's really gratifying to see that people have been coming for help. I mean, we know even before the pandemic hit that GPs are telling us the last 3 years running, when the College of GPs surveys them and says, what are the most common problems you're seeing in your clinic? Psychological problems top the list every time. Now, some people could say, well, that's a sign that there's a problem, but the counter view is that's a sign that people know it's a legitimate thing to seek help for. And also, hopefully, that clinicians are more aware of the delicate interplay between physical and psychological well-being. So, I mean, I'm certainly concerned by the modelling, but I'm also optimistic that we've come a long way than we were 20 years ago when we started, better outcomes in mental health care, that people do know that there is help available. And I think Joanne's comments about the system not then meeting people's needs is the biggest risk. And that's certainly been my experience in general practice. That
can I just interrupt you there? What evidence have you got that it's better now than before? I mean, we're spending $2 billion a year on psychological services by fee for service with not a shred of evidence they're making any difference to complexity and so on. They might be helping people in Turek and Armadale and Vaucluse with their mild mental illness problems. I'm not casting off at high prevalence distress, but it's not what we're talking about here is a pathway to really quite severe issues such as self-harm, suicidality, and so on, major distress. What I don't see. There's very poor follow-up from self-harm and EDs. We've got spending a fortune on psychological services, which are not doing very much good because the poor psychologists are working by themselves and not in teams. I don't understand where you're getting your evidence for that things are better.
Yeah, okay. So I'm comparing them to when I started in general practice 25 years ago, where a GP the stats showed that GPs were missing depression and anxiety, that people weren't accessing any treatment at all. We know that 1 in 5 Australians in any normal situation would have enough symptoms to qualify for a diagnosis like depression and anxiety. And yet now we have a situation where many millions of people have accessed care. So I absolutely acknowledge there are gaps in our understanding of the quality of that care. And I think that's why the Productivity Commission has called for a more rigorous evaluation of that. But I still think that's a positive step forward than where we were before, where we didn't even know whether people were actually picking up depression and anxiety. We offered training to GPs. We offered them a pathway where they could access psychological services. We're now having a slightly different problem where we're asking the question about, are we getting the best value for money from those services? But I still think in the narrative of accessing mental health care in the primary care setting, that's a big step forward than where we were, which is that people just didn't consider it a legitimate part of the primary healthcare system. But I acknowledge what you're saying. I think there are big concerns about the quality. My experience during the pandemic, though, in the clinical setting has been really interesting. I certainly have seen many more people seeking help, but I've actually found it in some ways easier to help them because they are presenting a bit more early. They're presenting with more in what if we're using medical terms would be more in terms of adjustment disorders. So before they've developed, ingrained sort of psychiatric illness. And there are things that you can offer them to help, and absolutely things like JobKeeper and also community supports and things do make a difference to those people. So I don't think we know yet whether we're actually increasing people's mental health literacy and increasing their help, or whether we're making it worse. And I think that remains to be seen. And I guess I'm trying to be optimistic for my patients, because in the individual clinic setting, that's our job, is to tell people there is help available. It's really important that you try to get help, but it's also important that you come back to us if the help you're accessing isn't working. And I agree absolutely that that's the big concern, is that if people enter the system and don't get the care they were hoping for early on, then we can lose them to care down the track, and therefore we won't be able to help them in the future. I think that is a big risk.
I mean, Tim was talking there about an early sign of distress in children, which is, eating orders presenting. Certainly we were getting, through my little podcast, lots of kids listening to it. Amazingly, it wasn't targeted at it, and many showing signs of distress. But here, what you're predicting is, and there have been studies, and I'll come to Jo in a minute to actually find out whether I'm right or wrong about this, but I thought when you're actually in an acute wartime situation, or there is a disruption going on, people cope quite well. And, the whole Blitz thing, remember the Blitz, it was all fine. But then when the structures around that acute situation fall apart, then that's when you get this delay. So you might be in a golden moment here where you're not seeing it yet.
I think that's possible, but I think it remains to be seen. I mean, I think things come in waves, and they come at different times for different individuals. So, I mean, the big challenge in general practice is it's funded like a population health intervention, and the PHNs see us as caring for a population. But for each GP sitting in that little private consulting room, they're seeing individual people. And I mean, I agree with Tim. I mean, I certainly hope GPs were aware of people's circumstances, their financial, social, family circumstances long before COVID hit. But it certainly legitimised those conversations. And then, the big data can tell you these are risk factors, but GPs are very used to interpreting that big data as to how it might apply to an individual. And I don't think there is an algorithm for that. I mean, even with the really well-tested algorithms like, the Wells score for DVT or the Central criteria for tonsillitis, the person sitting in front of you in the room, you still have to apply the sensitivity and specificity of that for that person. And it's amazing, even with those well-tested algorithms, how it's not that straightforward to apply it, but that's where the skill set is. And I think one of the problems with early intervention is it's often under-recognised how complex that is. And it's also quite hard to measure, just like it is how hard it is to measure the excellent kindergarten teacher or the excellent primary school teacher. These are people who have a huge impact on people's life and well-being, but we don't always know aren't so easily able to quantify it, because it often happens, it prevents bad things happening.
Tim?
I think a complicating factor, and Caroline's kind of touched on it, and a distinctive factor about mental health and mental illness is, unlike a lot of physical illness or health issues, recovery from mental health issues is not a linear process. So it is circular, and it's repeat circular, and it's learning, and it's seeking different forms of help and persisting until you get that right form of help and that right person that can help you in your recovery journey. So if we do have a wave, if you like, of mental health issues coming from COVID, we can expect that wave to be with us for some time, because it takes years, not months, to recover.
So Caroline, I just wanted to push a little bit harder there. I mean, if we are in a slight lull, now's the time to get ready. And general practice traditionally is not good at getting ready, because as you say, you're on a 10-minute appointment, 15-minute appointment schedule, and it really is sometimes very hard. You're so busy, hard to raise your head above the parapet. But you're going to get knocked over in the rush here, or not deal with it very well, despite the fact it's better than it was 20 years ago. I just want a sense from you whether you think general practice in Australia is so resilient that when the truck comes down the track at you, you're straight towards you, you'll be able to deal with it, or are there things we should be doing now, even though governments may not be responding that well?
Yeah, it's a good question, Norman. I think you are using some kind of alarming metaphors, like trucks hitting us. I think the pandemic.
I'm a journalist, that's the clear metaphor here.
Well, I mean, I certainly think the pandemic hitting us in March was a good example of that. So certainly in my career, the upheaval that happened when we got to March, and we realised that we ourselves were also at much more risk for our lives than we'd ever been before. Certainly any of us doctors who are above the age of 55, looking at the data that was coming out of Wuhan at the time, we were all going, gee, do we even want to see patients with respiratory symptoms at all? And I think the evidence shows general practice pivoted way more quickly than the government set things up for us. Thank goodness they did come through with telehealth. But it was the PHNs who said, here's a bit of money to put a gazebo in the backyard so you can swab people or see people with respiratory symptoms. It was the contractors working in some of these practices, because remember, a lot of GPs don't own practices, they work as contractors. But these doctors self-organised through Facebook and WhatsApp groups and shared ideas about how to put up splash trays and distancing things. They really adapted, I think, remarkably quickly, and all in the face of actually having a big threat to their business. And we've seen some of the data about the concerns about the financial sustainability of general practice. So I think most GPs would say, we're ready and willing to help people with mental health problems. We already do this as a big part of our work. We are concerned about the financial implications, because we know that to do good mental health care, unfortunately, with the way general practice is funded, it means you will lose money. And those of us who do a lot of mental health care can show you from our pay packets. So I think people are worried from the financial viability point of view, but in terms of us being able to say to people, this is the pathway to resources, I think general practice is ready. One of the things that we do struggle with is the system often creates solutions to improve the front door. And we saw that with the Head to Help, money that sort of set up all these hubs in Victoria. It sounds like a great idea, but the problem is you create the front door, but you don't necessarily create the follow-up. So, for example, just this week, I saw a patient presenting for the first time with anxiety, and she booked a half-hour appointment, which was a great start, but it probably took me 40 minutes to kind of really be clear what kind of diagnostic paradigm we were looking at. And at the end of that time, I really had the option of doing a mental health plan and sending her to a psychologist, which would be quite expensive and something she couldn't afford, or proposing the Head to Help model, which is really just a phone number that either she or I ring, which isn't, it's a great thing to get access quickly, but it's not necessarily the way to create the relationships that you need to get the integration, so that if that person goes off to see this service and it doesn't go well, or they need more help, the chance of her coming back to see me and me picking up where I left off for that 40 or 50 minutes that we invested in her problem isn't so good. And I think sometimes what happens is we design systems that kind of design it for the lowest common denominator of the health system and assume that all GPs are too busy and not able. I don't see that that's universal in general practice. And I think most GPs actually want to have that ongoing long-term relationship with their patients, but they do struggle in the mental health field because of the way it's funded.
Do you want to comment, Joanne, what you've been listening to?
Oh, sorry. No, I was just two thoughts came to mind. There's a lot of kind of pressure and expectation on, primary care to form part of the solution. Absolutely, they are part of the solution, but we also need to, think more systemically and think about what we need to put in place in order to prevent that wave of and that overwhelming of the primary care system, to stem the flow, turn the tap down, essentially, and that's going to take a higher order issue. The other issue I think Caroline really emphasised there is that it's not just about even having more GPs and more training, but the coordination between the services. So people really need coordination of their clinical care needs, as well as, often people have housing and vocational and educational support needs that also, we need a team-based approach, and that, person in the centre of care idea that came out in the Productivity Commission report is exactly what we need, that these things are coordinated. And at the moment, the system doesn't encourage that. It's very difficult for different services to share data on the same person. You're finding, consumers needing to repeat their story several times to different people, and it's really quite a big barrier to receiving good quality care.
So are you seeing people trying to do that, to try to get those interventions in, or you're just still advocating for them based on the modelling?
Mostly advocating. People there are groups trying to, design technologies that might help coordinate that sort of care, but, it's going to take a higher level buy-in. There may potentially need to be legislative changes that need to occur in order to be allowed to share data on patients between services. And so I think a broader conversation needs to be had. But of course, you know, this is not really my field. However, you know, there are a range of possible solutions that that people propose in order to deal with these issues. And you know, my response is always, well, let's throw it in the model first and see if it's likely to be, you know, produce good outcomes, because often there's a lot of ideas about what might work that may or may not or work, or maybe we need to, you know, think a little bit differently about the same idea in order to get it to have the impacts that that we're hoping it will have.
So the risk is that we waste money, throw good money after bad.
Yep.
Tim, Joe referred to the Productivity Commission, which handed down, was it the final report or the interim report? I can't remember, just a couple of weeks ago. What were its key findings in terms of informing this discussion, which is that we could be in a lull before quite a considerable problem emerging, you know, in the middle of next year?
I think the key observations is really around the dysfunction of the system. So really, we don't actually have a good operating mental health system. We've got a number of subsystems. So there's the system that is commissioned by the PHNs. There are services commissioned directly by the Commonwealth Government. And then there's state services, whether they're tertiary hospital or non-admitted services. And as Joe and Caroline have highlighted, the services don't integrate well together. And as a result, and partially as a result of there not being a system architect focus. So who's standing back and actually viewing the continuum of mental health services and supports as a system of services, as opposed to intervening with individual services? And I think that's what the Productivity Commission was trying to get at when it
Well, you were the Mental Health Commissioner and you were the system architects, one of the few jurisdictions in Australia which allows that to happen.
Yep.
What happened?
Well, we drove a system as opposed to service interventions. We diagnosed the system first, so going back to Joanne's work around the modelling, and then we used that modelling to drive all of the investments that we made in system development. But we're a long way behind the pace. We're not starting from a good starting position. We've got a hell of a long way to go.
And what are the building blocks then? I mean, people at Brain and Mind Centre really talk about, you know, assertive follow-up after self-harm, that you could actually reduce the number of people dying by suicide by simply doing that intervention where you've just got active follow-up.
Yeah.
Which could be by the general practitioner, but also could be by a team or a team supporting the GP. I mean,
so that's a great example. What we did with a systems focus there is we reported the percentage of follow-up within 7 days by of people that had been through ED or discharged. When we started to shine a light on that, we were running at about 55% of people being followed up within 7 days. We continued to shine a light on that data until, well, we still do it now, but we actually reached for the first time the 75% target, which is the national target, and then we exceeded it and achieved 80%. So the power of data and performance management is really, really important in any system, but particularly in mental health, where it is so dynamic.
and how did you bring together the diverse areas? Because you know, the state funds community services, hospital beds, people, you know, mostly biased towards people with low prevalence but high impacts mental health problems, and then you've got the Commonwealth funded system on the other side. How do you bring those two? How do you manage to bring those two together?
You've got to have strong relationships, and you very much need integration of services and clear pathways between primary health and tertiary health, between state-funded services and PHN or Commonwealth-funded services. And that's not always easy to achieve. In fact, it's probably the hardest thing to achieve in this space is collaboration across services. And then what that leads to is an incredible difficulty for individuals to navigate to the right service for them, because usually they're only trying to do that when they're in a situation of distress.
Caroline, we have governments that profess to care about mental health and put it as a high priority. What can happen at a sort of guerrilla level to create facts on the ground which just get beyond the lonesome cowboy, and not cowboys, it's very unfair to say that, but essentially the general practitioner working in isolation by themselves? How can we start that, really extend that conversation to get effective care? We've been talking about this forever, and the statistics are still appalling. But despite the fact that you say it's really good compared to 20 years ago, the statistics are crap. What can we do to actually improve this in a systematic way?
I think it's hard, isn't it? Because we always view it through the lens of the chair we sit in. And so certainly for me as a GP, I wish some of those other mental health services would start seeing me as their customer, so they'd actually would tell me when a patient of mine had presented to ED and was suicidal, that they would actually communicate to me when they'd done any investigations, that they would then write to me and say, this is what we've recommended and here are some services. At the moment, it often feels like a one-way street. So I think, but again, I'm viewing it clearly through the lens of a GP who's trying to help people who come to mind.
No, but we could have had this conversation 20 years ago, Caroline, and you'd have said the same thing, and it hasn't improved much.
Well, I think that's because that communication between the state-funded hospital system and the Commonwealth-funded primary care system, we still haven't cracked that nut. And I think part of the problem is that we keep focusing on mental health as the poor cousin of physical health. I mean, if you look at the money that we're spending on mental health, everyone says, oh, we've done all this and it hasn't worked, but it's still relative to the money we're spending on physical health. It's just too little. And just like with physical health, we know that people in the richer postcodes and in metropolitan settings get more care, as do people from social advantage, they get more care. We don't talk enough about the wastage there, the kind of physical hospital care that's wasting money. Yet in mental health care, we scrutinise to the point that, we're now questioning whether people should be able to go and see private psychologists. I mean, I think the challenge is that mental health care just is not funded adequately relative to the burden of illness that it causes. And it's because it's complicated. And I think, but it's also because of stigma. I mean, I see it even just in my day-to-day interactions with my friends and family. If someone has cancer, everybody's there making casseroles and offering to pick up the kids and doing all kinds of stuff. If you end up in a hospital because of a mental health crisis, people don't come near you. They don't even know what to do or what to say. And that to me just represents the kind of values and the fear we have about mental health. And it's exactly the same with the issue about Centrelink and disability support pension and NDIS and JobKeeper. This narrative that these people are somehow not worthy of the same level of care as people with other types of illness. And I think that's the culture shift that we really need to work on, because I think the people probably on this webinar all believe that they are worthy, but I don't think we've yet got a system that says that the investment should be the same, even though the economic argument there, I think, is pretty clear.
Let's go to a couple of questions, because we're coming towards running out of time. Really good question here, which is there evidence from other disruptive events globally about the long-term impact on mental health or distress? I'm adding distress here, it's not the question. For example, in Greece, post-GFC. I mean, Joe, you're part of an international group of modelers in this area. You've probably looked at this. Are there examples elsewhere where you've either seen this or not?
I think the literature is quite clear in the the adverse mental health impacts and suicide impacts of recession and of the global recession, and the devastating impacts that high levels of unemployment can have in terms of reducing a person's sense of agency and control over their lives, and resulting stress, increasing vulnerability and risk of suicide, and particularly that idea of accumulated stress over long-term periods of unemployment, which you saw in Greece and other places, is particularly kind of devastating. And there are systematic reviews that show that that you get a slight increased risk, but over time, as you get that accumulated stress, you start to see much bigger risks of really quite bad mental health outcomes. So it's, but as I think has been pointed out earlier, this is unprecedented, this kind of coupling. Well, it's not unprecedented in my lifetime, at least, of this coupling of a pandemic and major global recession. And so, when we've looked at the literature historically, where there's just been recession, it's been devastating. But I think with the addition of COVID, I think there's another level, and the associated lockdowns, there's another level of distress being created. So I think we can look historically, but we also need to kind of be continuing the data collection process and improving our understanding, but it needs to feed into something. It needs to feed into something that will help people make better decisions, rather than looking at individual programs and services and initiatives. We need a kind of coordinated systemic response.
Tim?
Yeah, absolutely. And it is that coordinated systemic approach that it's the missing ingredient at the moment in a strong functioning system that is person-centered, that's centered on the consumer, the carer, their families, and what they need. And I think in terms of historical events, if you go back to 1961, being a bit of an economic historian, there was a severe credit crunch in Australia in 61. And there was quite a spiked increase in suicidality. But that credit crunch was only 12 months long. What we're seeing now is a credit crunch plus job loss, plus health insecurity, plus for an extended duration of time. So history would tell us that we're in for a surge in demand and distress in the community.
Another question for you, Joe. Does the COVID scenario modelling indicate whether there are specific extreme gaps in supply, presumably services, that are a priority to address?
Good question. You mean service capacity, like what aspects of service capacity?
Yeah, where would you put your priorities, or can you generalise, or is it specific to regions and locale?
It would be specific to regional dynamics between, demand and supply, but there is most certainly significant capacity limitations of specialist mental health services that we need to address in order to meet the demand that's coming our way.
So do you see any signs that state or federal governments are listening to the modelling?
There are occasionally signs, but in hearing one's words come back at you. But I think in terms of taking on board the general approach, in the same way that governments took on modelling for responding to inform their response to COVID. I don't think we're seeing that in mental health. I think, at the beginning of the pandemic, we saw Scott Morrison standing with a graph of the wave to come and saying that, we've engaged with the modelers and this is what's coming and this is what the modeling's been telling us we're going to do about it. If we could see that same approach to mental health, that same discipline, I think we would go a long way to tackling this effectively, but I'm not seeing that engagement yet.
And a final question, but for all three of you, from Lauren Ware-Morand, which is, what are the key silver linings to take from COVID for the mental health system? Is there anything good to say?
Well, I'll kick off. I've learned a lot about resilience. So amongst all the people with distress, I've also met a lot of people, particularly older patients who really had the most to fear from dying from this pandemic, who were amazingly strong and resilient, who adapted to all kinds of things that you wouldn't expect them to adapt to, and came through and were grateful for the care they received and were grateful for their family stepping up and help them. So, and I think, and of course, telehealth is the other absolute silver cloud in this, that we can now connect with patients. I mean, it has a lot of potential to help. There's got a lot of technical details to be worked out, of course, but it has a lot of potential to move us into a modern world where we can communicate with people who need to be contacted without relying on them sitting in an office waiting room for hours at a time. So I think they're two kind of things that have brought me hope from this experience.
Jo?
I would say generally the modelling literacy that's come from this, you know, there's a lot of armchair epidemiologists around now, which I think is fantastic because, you know, people are starting to ask the question, well, you know, why aren't we using this for tackling mental health issues? And if we can get a kind of a broad community of people demanding this sort of approach to investing in our mental health system, then we can get that engagement in terms of getting groups of people together to co-develop these models. These models shouldn't be built in back rooms by, you know, academics. They need to be brought out into the open. They need to be transparent. And in order to do that, you have to have a kind of a general literacy in the community and amongst service providers. So, and I'm starting to see that now, and it's really great.
Tim?
I think there's two things from my perspective. One, a growing awareness that you don't actually have to have a diagnosed mental illness to be experiencing mental health issues. And it's people's circumstance that often determines their mental health as opposed to an illness. So I think there's a growing awareness of that, and a growing awareness also of the need for services to respond to that. I think what we need is a system that responds to that, not just services.
Look, that's been a really illuminating discussion and really enjoyed it. And I think the people listening would have got a lot from watching, would have got a lot from it too. And thank you, Joanne Atkinson, Caroline Johnson, Tim Murray. Thank you very much for joining us today on this special panel. And I'll hand back to you and Sheldrake.
Thank you.
Thank you, Norman, and thank you very much, Tim, Caroline, and Joanne. And Joanne, as somebody whose academic background and early part of my career was in systems modelling, I can empathise with some of the frustrations of how modelling is used selectively. Before I close, I'd like to remind everybody that this is the fourth in a series of 5 webinars. The final one is actually tomorrow due to a range of availability. We're really looking forward to tomorrow's one. It's going to be a focus on the impact on children and young people across Australia, which we did touch upon a little bit early in this conversation, but we've got some great guests who are going to participate in that conversation. So please do sign up for that if you haven't already. Those who have bought a pass to all of the webinars, we look forward to seeing you tomorrow. And we wish everybody a good afternoon or good evening, wherever you are. Thank you.